Thank you so much. It's lovely to see you all here. It's a minor miracle that I'm actually here because I got completely lost. And if I hadn't bumped into Progista, I would be giving this talk to inorganic chemistry. But perhaps that's a bit of a helpful analogy because I'm going to talk to you about some very new and really difficult research that we are only just starting to wrap our heads around. And I think that for you, who all have your research projects and your leadership of research initiatives, to start, perhaps to start thinking about these challenges too, to look at how we've started thinking, and to feed in and support mutually in trying to wrap our heads around this huge challenge of global threats that are facing many countries, but in particular facing Africa. And so first, I just want to start by taking a step back and thinking what forced us to start thinking about this. I started my career as a social worker in South Africa before we had antiretroviral medication. And what I saw was two things. The first thing was the horror of trying as an individual to cope with a crisis for which we had not got sufficient response, but also where that response had not reached Africa, where we knew that people living with HIV in America were receiving antiretrovirals, and every single one of my clients was dying. And the second thing it taught me was that children come last. It took 14 years of the AIDS epidemic before anyone wrote a report about children. And it made me think about looking into the future, trying to anticipate the crises that are coming for our continent and our world, and to try and prepare the research evidence and adapt the research that we are doing anyway to try and meet those challenges, to be ready to meet those challenges in a way that we really weren't with HIV. And so what are these challenges facing us? The phrase "a new world of polycrisis" is not mine. It was the UN Secretary General. And in many ways, I find it terrifying to think about this. You look at these kinds of stories and reports around climate change, around increasing conflict, around climate-related increases, for example, in cholera and hemorrhagic fevers. And part of me wants to sort of sit under the table and cry and read something, watch Sex and the City instead, because it makes me feel better. But we also have to try and think that if we keep doing our research as is, without building this coming reality into it, we are not going to meet the needs of the people we're trying to serve, but we're also not going to be able to address the way in which policymakers are going to have to be delivering services. And so I tried to think, what are these big threats coming? Well, first, we've got clear new threats. IPCC says that Africa will be most severely impacted by climate change, with Asia following rapidly after. But we also have more need. We need for many of our interventions, and here medicine has been far better in social work. We have to think not just about interventions which reach 1,000 people or 100,000 people, but interventions which reach 10 million people or 100 million. So we have to think about national level scale, and we have to think about crises which are proliferating. We are no longer in a humanitarian world where we have isolated, small and manageable crises where a humanitarian response can fly in, deal with it for 6 months and then leave. Some argue that never worked in the first place, but I think everyone is clear that over the next decade, that will no longer be a feasible response where we distinguish humanitarian and general medicine and responses. But we also have to face this last crucial aspect, which is that international aid is flatlining or diminishing, and fiscal budgets are not growing in the countries in which we are most interested. And so we have to think, how do we respond to new challenges, greater need with less cash? Do you want to hide under the table yet? But we also have amazing opportunity. Last week, I went to US Congress to try and persuade them not to withdraw $6 billion worth of aid per year to Africa. And I showed them this graph, but at the top of it, it said, Africa, the new global market. Because, and this I learned from Kevin Marsh, we have a powerful argument of the power and influence of the regions where we most want to protect. And we can use that power to argue and think about what services, what mass services we can provide, but also to think simultaneously about our responses in very different ways. I'm going to talk a bit about some of those. But ultimately for me, and you're all looking at different things, but for me the challenge is that in 10 years' time, when we're looking and living in an Africa which will be experiencing a greater number of climate, potentially conflict, and potentially epidemic crises than we have ever before, we can look back and say, we are so glad that we started that research in 2024. And so what are we starting to do in a tiny part of this huge challenge? Well, this is some work led by Pavena Atagani, who was on the IHTM course and is now doing her doctorate. And what she's been doing for the last 2 years has been overlaying the violence against children surveys, which are a CDC set of surveys across Africa, with drought data, standardized satellite drought data, and conducting a fairly familiar multivariable regression with country-fixed effects. And this is just a sample of some of the findings that we are seeing. We are seeing that on an outcome which has not been connected to climate change, that we are seeing double rates of experience of past year violence and doubled rates of past year transactional sexual exploitation in situations of extreme drought. We're seeing the same for physical and emotional abuse. Something is happening within these families and in the support network and protective network for particularly girls that is meaning that child protection and climate are inextricably linked. And then we have to ask, do we have to develop new methods for some of these really challenging, complex questions? This is some work led by William Rugger, which he's doing with the Western African office of UNICEF, and essentially looking at floods in Nigeria, really trying to understand how might we be able to understand the impacts of floods. Now, if you look at what UNICEF is doing, UNICEF's doing this big climate risk index. I don't know if any of you have seen it for children, and it does it on a country level. But what's crucial here is what Will is finding, which is that country level analyses are not sufficient in helping us understand the impact of drought and floods. What he's finding is that when we drill down to a local district level, which requires some quite substantially more complex methods, we're now starting to see some severe impacts for children across multiple areas. And so we might need to start thinking. I think that what I often do in research is you use your traditional way of thinking with like a new variable. So you think, well, when this new thing comes in that I haven't dealt with yet, can I slot it into my mental map of how I analyze things? And I think we're just starting to learn that we're having to shift those mental maps for these new challenges. And a particular challenge of this is that we're seeing climate change. A drought does not respect a country border. A cholera outbreak does not respect a country border. And so we're having to rethink some of the ways we do models. But mainly what I want to talk about is early thinking about what solutions we may be able to reach. And I think this is because increasingly when we read the climate literature, it's all about the risks. And we have to push through that and say, what are going to be the scalable solutions? And so this is based on a literature review with about 100 articles that we could find, most of them qualitative, of trying to think, are there common pathways to these risks. If we think about climate change, disease outbreaks and conflict, are we seeing, particularly for children, a set of shared things that go wrong in a home, in their community, which are leading to these outcomes? Why does that matter? It matters because if we are seeing shared pathways, we may be able to develop interventions which interrupt the impacts of multiple crises or the impacts on multiple different outcomes. And there is some evidence for this. We've been working for the past 5 years, mainly with WHO and UNICEF, as well as UNDP, to identify accelerator interventions which have simultaneous impacts on multiple outcomes at the same time, particularly for children and adolescents. And here's just an example of one. This is led by Yanina and Titello at UCT and Oxford, where we were looking at 1,000 adolescent mothers in a longitudinal cohort in South Africa. And we asked what things out of a selection of 30 different potential provisions are giving the best bang for buck, are improving their outcomes as much as possible. We know that adolescent mothers experience a whole set of really challenging health, nutrition, education, violence, and HIV risk outcomes. And what they found was that the most powerful combination for this group was a combination of having enough to eat, having non-violent parenting of the adolescent, most of them still live with a parent or caregiver, and having a health clinic where they didn't get shouted at when they went to get help. If they receive just those 3 things, we see this level of improvements. For example, we see that school dropout goes from almost half to 35%. We see that contraception use, that having sex without contraception goes from 30% half to 14%. We see rates of age disparate and transactional sex halving. We see mental health distress halving. So we are seeing over and over again throughout the region that simple combinations of interventions can improve multiple outcomes. Are these going to work in climate change context? We don't yet fully know. But we've got some very, very early evidence that it might do. This is some work led by Hernando Hurtado, who's also in our department. And what he's been looking at is using the multiple indicator cluster survey in Nigeria, overlaid by satellite data on conflict. And ignore the soil moisture index. That's what economists do when they want to create a causal model. Economists work differently. Anyone here an economist? We might make you explain IB approaches. But really, I think the key thing to focus on here is that we've seen that conflict is increasing children's food insecurity by 30% in Nigeria. That may not be a surprise to us, but we have to then think, well, what will mitigate? The literature and the large-scale evidence on that is actually really thin. What he is finding is that where a family receives a cash transfer in the household, that's either through a government service or through something like an educational subsidy, we're seeing a substantial mitigated effect. I tried to make them do bar charts, but economists don't like bar charts. But it's starting to tell us that we may be seeing that some of the interventions which we are providing for other purposes might be able to help in these contexts. And there's been some really interesting research in Bangladesh, which is primarily focused on adults, but which has found similar outcomes. I also want to think about the opportunity we have being here at Oxford. This was led by Mona Ibrahim, who is another IHTM alumni. I try and steal some every year. But what she did was to take advantage, she's Sudanese, and had been feeling deeply upset by the lack of international funders and agencies to be able to think of new ways of supporting people in Sudan, particularly with the challenge of the fact that with the war, many of them had withdrawn their aid and were giving aid to surrounding countries instead. I mean, for understandable reasons. But this is what's really interesting that she did. She used the convening power and the academic neutrality of Oxford University to bring together a set of donors, funders, government partners, and civil society together in an environment in which they could never have all come. So FCDO, CEDA, Irish Aid, USA could never have gone to either of them to have had such an open conversation. But they could all come here, and I think I'm showing a one-off example of Nuffield Formal Hall. But really to think about the fact that being here is not just about who surrounds us, who we can learn from, or where our funding is. It is also an opportunity, and one that we can leverage for really quite an extraordinary amount of good. And if you have more questions, we'll ask Mona to come and tell more about this. It's still underway. But I think we can also start thinking about our research in really pragmatic ways. This is a study of parenting programs. Parenting programs currently the most effective prevention mechanism for violence against children. 435 randomized trials showing they're effective. We know that the good ones work. What we didn't know is whether the good ones work in real world conditions, when delivered in the craziness that anyone who has worked outside a lab knows as reality. And so over 6 years, a group of parenting programs, Oxford had developed a set of open source parenting programs that are now WHO and UNICEF's programs. Everyone who delivered them in Africa, we just asked them if they'd be willing to put out questionnaires for pre and post. And so we're able to collect 121,000 participant data across countries, including settings. And what we see is an overwhelming positive impact across in real world conditions. And we're able to use this kind of evidence to argue for the delivery of the kinds of programs that often a government, how can I put it? The Gates Foundation will say, where's the randomized control trial? A government will say, randomized control trials are all very well, but we know that you do them. You put in a bunch of stuff to try and make those things work. Show me what happens in the real world when this is delivered by my healthcare workers or my community health workers or the NGOs that we are subcontracting. Another way of we're trying to think around this kind of challenge of scalability and scalability in crises is to think about new opportunities around digital delivery. Now, of course, digital health, medicine has gone much further than child protection and social work in thinking about digital health. But actually, overall, we're not doing great on this. A meta-analysis recently of uptake and retention rates for digital health interventions. Can anyone guess what the range was of uptake and retention for digital health interventions? I'd guess 60% originally. It's between, I think, 2% and 22% for retention of a digital health intervention. We would not accept that in any clinic as a retention rate. And so we have to ask ourselves, can we take the opportunity of digital health interventions and adapt them so that they are not only scalable, but scalable and usable at a population level? There might be another opportunity in digital health interventions. So I do not know what this is like in the medical field, but what happens in development is that every NGO or every academic group creates their own intervention, right? And then we have our own intervention. It's like our orange. We're like, here's my perfect orange. People, can you fund me to test my orange more or to deliver my orange to people? But that's actually a particularly inefficient way of delivering services to large numbers of people, and especially in a crisis situation, where we don't want to be trying to deliver an orange, an apple, a satsuma, and a banana, all from different NGOs or with their own program. What we want to deliver is something really simple that combines those effective programs. And so with this test of a digital health program, we took an effective parenting intervention and we contacted the developers of an effective sexual violence prevention intervention, effective HIV prevention intervention, and effective mental health intervention. And we said, will you just share your programs and we're going to combine them all in one and see what happens. Quite a few people said no, but several said yes. And so we were able to test what happens when you can combine and bring down costs through a digital delivery. It took us 5 years because when we tried digital alone, it didn't work. We got a 25% retention, just as we should have known had we done the had the meta-analysis existed before we started. We then stole an idea from the International Rescue Committee, which was that we combine the digital intervention with WhatsApp groups, with 50 families in a WhatsApp group, and a facilitator who spent an hour a day over 12 weeks with that WhatsApp group. And I'm going to show you immediate 1-month results from a randomized control trial in Tanzania. I'm happy to answer any questions on methods, but I suppose just a large RCT, cluster RCT, unintentionally delivered through 3 epidemic outbreaks. That was not part of the study design. But this is with quite young children, aged around 13. And just to get a sense of what the results are showing initially, we're seeing very substantial impacts of this hybrid intervention. It's both hybrid in terms of being hybrid digital and human delivery, and hybrid in terms of being combining interventions together on outcomes across the goals of these different programs. Perhaps most crucially for delivery and for conversations with governments, the delivery cost has gone down from around $60 per family to $6 per family. And this is probably for the first time that we have ever had a child abuse prevention intervention that is both effective, hopefully, but also scalable to governments which cannot afford higher cost interventions. And so I'm going to end with something which we are working on, but which we have no idea how to do in crisis settings. And I'd love to get your thoughts and impacts, but I think it's a crucial part of the puzzle. So I suppose to get back, over the last 10 years, we've worked consistently with governments, and we always say to them, this is governments in Africa, we always say, what do you need? What do you want from research? They tell us a lot what they don't want from research. But one of the consistent things that comes out is the idea of bang for buck. Ministers of health will say, I've got to go to Treasury. I've got to deal with 30 problems. And then I've got to go to Treasury and I've got to argue to my finance minister why I should get money for these. And if I can demonstrate that my priorities are both cost effective and impacting other priorities, for example, education department's priorities or criminal justice department's priorities, then I've got more leverage. And so we've been trying for the past 4 years to develop an economic modeling system that allows for multiple outcomes instead of just single outcomes. I mean, health economics has done brilliant work on single outcomes. We know how many bed nets we have to buy, that it reduces this many cases of malaria. We've been less good in thinking about multiple simultaneous outcomes across sectors. And so we started with a review of 260 papers to try and find what were accelerator interventions. We found 3 accelerator interventions that we prioritized in consultation with a whole bunch of stuff with UNICEF and 5,000 adolescent girls. And those 3 were adolescent-friendly health services, not being shouted at, being treated with some respect when you go to the clinic. Some kind of economic support. This normally says cash transfers, but because I presented the slide to the US Congress, they don't like the word cash transfers, so it became economic support, which is a little more comfortable for them. And effective parenting programs. And then we did a whole bunch of systematic reviews of those, with a focus on Kenya. We chose 1 case study of 1 country. We then built, and when I say we, I did not do this amazing team did this. We then built an analytic framework to try and understand not just how A leads to B, but how these things might interlink across each other. And every time you can see a line there, that's because there's randomized control evidence showing that we're seeing interlinkages across these pathways. And then we took 3 separate economic models, the health model, Spectrum, many of you may have used that, combined with an education model from UNESCO and a violence model, and linked the 3 together. We then collected cost and implementation data at government level, working with the Kenyan government to try and develop that as accurately as possible. So this is the kind of stuff very familiar in health economics, where we're breaking it right down to understand how many people, how long we're training, how much we're. And this is the outcome. An investment of $24 million per year in these 3 accelerator interventions for adolescent girls. These are just 3 examples. It's not saying these are the full answer. Result in a set of key measurable outcomes that you'll see in white in the middle. 7,000 fewer child marriages, 241,000 more years in school, 120,000 fewer child pregnancies, 8,500 fewer cases. Again, I apologize, this did say child sexual abuse. I went to speak to US Congress and had to change it to child sexual trafficking. That's what they used. And these outcomes are going across different sectors. They're going across education, they're going across HIV, they're going across health, and they're going across violence prevention. But what is crucial for governments and for donors is the thing on the far right, which is that when we model that over the next 40 years, we see that that $200 million investment produces a $918 million return in increased labour market productivity. Possibly for the first time, we are able to try and show that social and health investments are resulting in macroeconomic impacts for adolescent girls. We've also got some costings of antiretroviral costs, but I think this is really still underway because we're going to try and now use the One Health model, WHO's One Health model. Any advice on this, welcome, to try and understand that and increase that. We're just looking at commodity costs at the moment. But overall, what we're seeing is a $4 return for every $1 invested. Now, is this totally accurate? Would we use this for, say, a clinical program design? I'm not sure. But what this is demonstrating that we have a powerful tool for arguing for the benefits, not just the moral and ethical benefits, not just the health benefits, but the benefits to an economy of investing in a vulnerable, particularly vulnerable group. And so a big challenge that I have to ask, we're trying to ask ourselves now is, can we do these kinds of models in crisis situations? I mean, we could just run them in crisis context, but to try and understand and think through what are going to be the impacts of these crises on our economies, on capacity for labour market productivity, for example, on increased rates of sexual violence. And can we start to develop not only the reasons for investing that we all understand, but the reasons for investing that when I sit down in front of a Republican set of lawyers in US Congress, that they appreciate and understand. That dollar return on labour market productivity links right back to Africa being a next trade partner over the next 20 years. And so I end with a set of ideas. These are not answers. But can we start to think about a next generation of interventions? Can we think about bang for buck combinations? And maybe that means we have to stop thinking in our disciplinary sections. We have to stop thinking that I'm in medicine and you're in child protection, or I'm in this part of medicine and you're in this other part of medicine. But start thinking about how we can deliver things in combination. Can we think about innovations in delivery which can drive down costs and which can survive something like a pandemic to come? And can we start thinking in hard-nosed ways about return on investment in a context of less cash, more need? Can we make the argument that investing in the most vulnerable in Africa is really worth it? Love to hear your thoughts, comments, and criticisms. And we're always open to colleagues joining us and thinking and working together on these challenges. Thank you.